to the organizers. I will be very quick, not just because David and I have to go, but we want to try to get to the questions if possible. Let me start with my conclusions, which is on the substantive side. Sorry, I'm going to speak up so that people on the phone can hear. Around smoking. And the conclusions are really a few. First, on current patterns, there'll be 1 billion smoking deaths in this century, much of that occurring among people that are already alive today. And that's one of the key strategies for public health, is figure out how to get current smokers to quit, which I'll come back to. The second is really recent evidence has suggested that prolonged smokers lose a decade of life. And we've only learned this really just in the last year and a half consistently across populations. And that cessation is ridiculously effective. If you quit early, you avoid almost all of the excess risk of continuing to smoke. The next point, which I won't spend too much time on, is the World Health Organization goal of a 30% reduction in smoking can really be achieved by tripling the excise tax. And it was good to note in the recent budget, Jim Flaherty did raise the tax. In real terms, it's about a 5% increase, and that'll lead to about 25,000 deaths avoided in Canada from tobacco. And finally, the focus of this symposium on monitoring. There are various strategies possible. And of course, the one that is very familiar with the group here is using prospective studies, for example, CCHS, and linking them to the important work that Mahmoud and Nelson had described about linkage, for example, to mortality outcomes. The key here is really to do that carefully and to take into account the important issue about prolonged smoking is really what you need to measure to get the mature risks in a population. And that's important also to avoid reverse causality, where you have many people quitting smoking as a result of disease. And those two need to be carefully done in epidemiological work, but this really yields robust answers, as I'll show you from the United States. Also quite relevant to the ICES work are the indirect methods, in particular the Peto method, which involves taking the absolute lung cancer rates in a population and then indexing that to the relative risks from other diseases using American prospective data. And that Chintani, my collaborator, and we have updated that indexing to use more contemporary measures than the older data. And that has a particular implication for women's risks in terms of not underestimating, as I'll show you. For developing countries, there are other methods that are possible. Simple retrospective case control methods where, for example, in India that we've used, where you ask, did you go to a household, knock on the door, interview the person about the death and obtain what's called a verbal autopsy, and ask whether the dead person smoked, and you also ask the living person whether they smoke. And you use the living population as controls in an unmatched way to the deaths to be able to study the impact of smoking. The other method, which might quite well be relevant to Ontario, is this idea of using proportional mortality. And that's simply asking whether the excess of smoking among those that have died of tobacco attributable conditions is greater than those that are from diseases not related to tobacco. And this has been used beautifully in China in a study of 1 million deaths, recently in South Africa by 2 groups, including us, and in Bangladesh. And this might well be practicable even in Ontario. And what that would involve is a simple question: did the dead person smoke about 5 years ago? Definite yes, definite no, do not know. That's really what it takes to be able to do quite beautiful epidemiology. So let's start with the really important aspect of understanding tobacco epidemiology, which is the lag between exposure and deaths. If you look at the peak of US adult consumption, which is shown in the blue, and look at the peak of lung cancer deaths in men, there was a 30-year gap in the United States. In women, it was even later. Currently, if we look at the patterns, for example, in China, the lung cancer rates are continuing to go up, even though smoking, well, in China actually smoking continues to go up. In Indonesia, it continues to go up. So the peak of the events that are going to be related to this increasing in smoking is really a few years hence, a few decades hence, excuse me. Now, these two gentlemen don't need introduction, but Sir Richard Peto and the late Sir Richard Dahl really have quantified the tobacco epidemic reliably in the 20th century. I was very privileged to have Richard as my supervisor when I did my PhD, and I've continued to work with him. One of the important things that came out surprisingly recently, actually this was shown on October 28th, 2012 in Oxford, when there was a symposia to honor Dahl's 100th birth centenary. There were about 5 studies presented from around the world that showed the 21st century hazards of smoking. So one was the last study that Richard Dahl did, which was in UK doctors, showing a decade of life lost for prolonged smoking. Valerie Burrell's study of UK women also showed a decade of life lost. Our 2 studies, which I'll show you in the United States, using the National Center for Health Statistics prospective study, showed also about a decade of life lost in Japanese men and in women that survived the atomic bomb and were followed up. They also showed about a decade of life lost. And Indian men who smoke cigarettes in our retrospective study appear also to be at that level. So this was remarkable. You think, we've studied tobacco epidemiology for 60 years, yet it was only at this meeting a little over a year ago that we got the contemporary estimates worldwide. And this paper was summarized by Brian Williams from NBC, which I'll just show you how he did it.
Good news and bad news on the smoking front. And good news and bad news on the smoking front from the New England Journal of Medicine. They state flat out smokers lose at least 1 decade of life expectancy over non-smokers on average. The encouraging news here is quitting before 40 reduces the smoking-related death risk by 90% compared to continuing on as a smoker.
60 years of epidemiology in 22 seconds. So what is the U.S. study they did? And this is an important method which I think is increasingly relevant. This is linking a national survey that was done to the National Death Index. I call it the Facebook of death. And a very simple strategy. Take a random sample of people, interview them about what they smoke, what their self-reported weight, various other factors, including health insurance, and then follow them up using very careful measurements, which I think we can have a follow-up seminar, which involves correct measurement of deaths in middle age. My definition of middle age changes as I grow older, but I'm going to stick to, in the Western sense, about 25 to 79. And the key finding is that women who smoke like men die like men. And now the mature risks are threefold for smokers, meaning at least a decade of life lost. And this is very different than if you did the epidemiology earlier. Mike Toon's companion paper in that same New England Journal issue showed that using the prospective studies in the US, if you would have looked at the first, what's called the ACS-1 prospective study, they really found very little difference in the smoker-non-smoker death rates in women. And that had gone up a little bit by 1982 when the second ACS was done. And the more contemporary cohorts, which Mike analyzed, showed the same relationship that now is existing in men. And this was simply because these studies were not studying what you see today in the, if you watch that show Mad Men, you see everyone smoking away. Well, the women smoking in that video had to be followed up about 50 years for really getting the contemporary risks reliably measured. And that's what we've got today, so a full decade of life lost. And this, expressed in survival probabilities, means that basically 70% of never smoking women in the US can expect to reach age 80. And it's a fair proposition. You can't live forever, but living in good health till age 80 is a reasonable one. Whereas only 38% of current smokers can, even if you adjust for all sorts of things. That's about a decade of life lost. And similarly in men, it's even steeper. So the good news is that because the risks of smoking are so big, the benefits are also quite big. And those that quit by an average age of 30, but between 25 to 34, get back almost all of the 10 years of life they've lost. Those that quit by 35 or around 40 get back 9, quit by 50 get back 6, quit by 60 get back 4 years of life. And this is shown very nicely in Valerie Burrell's study, or the Million Women study, about women who quit smoking at different ages. And yes, there is a continuing risk, a relative risk of 1.2, which is quite large among those women that smoked by age 40. But you have to compare that, this 20% excess versus a 200% excess among continuing smokers. And for lung cancer, it's even greater. Now this, when applied to population level statistics, shows where cessation has become quite common, like in Canada or in the United Kingdom, the enormous improvements that we've had in cause-specific mortality. For example, cancer mortality among men, you look at the huge decline that occurred in lung cancer mortality rates, almost all of which is attributable to decreased cigarettes. Now, there are other declines in cause-specific cancers which are attributable to treatments or other interventions. And in Canada, we've also had an enormous decline in vascular death rates over the last about 4 or so decades. And again, much of this is attributable, not all of it, but much of it is attributable to smoking and also to secondary treatments. You put those together, and these slides that Richard Peto has about the contribution of smoking to deaths using his indirect method in the United Kingdom has shown this continuous improvement. Smoking in 1960 or 1970 used to account for about half of all the deaths in middle age. Okay, that means rush. But now it's really come down to less than a quarter. The same in women. In China, it's simply 40 years later. The proportion, the delay of the cigarette increase occurred 40 years later, and sure enough, the proportions of deaths due to smoking in China is rising, such that by 2030 they'll look like what the United States looked like in 1990. If you currently measure the risks, however, from various epidemiological studies using those 4 methods that I described, you see mature risks now in the US, UK, Japan, and among Indian cigarette smokers, but other populations are still showing immature risks. Now, notwithstanding that, we know that there's about 500 billion people, or 500 million people below age 30 that smoke. And for them, the proposition worldwide is about a decade of life lost. We know that, and we can safely say that now. Well, what do we do about it? Again, not a focus of this seminar, but the most important thing is to raise taxes. In France, which you normally wouldn't think of as a place with really good tobacco control, Jacques Chirac raised the tobacco taxes by 3-fold, 5% above inflation every year. The prices doubled, and consumption fell prices tripled and consumption was halved. And then later you see this plateauing. That's when Sarkozy came in as finance minister, and we're hoping that François Hollande will be able to increase this further. And the same phenomenon is seen in South Africa, an inverse relationship. They were able to have consumption in a very rapid time frame. And the French example of using mortality statistics is worth a comment. In using the routine statistics, if you look at the lung cancer at young ages, which is a good measure of recent exposure to smoking, there was an inverse pattern. Good declines in the UK, but increases in France. This is up till 1997. But look what happened after 1997 in France. Boom. Big declines in lung cancer, which is partly attributable to the change in the type of cigarette from the higher tar to lower tar, but mostly because of that decreased consumption. And the female epidemic, which was going up, has basically plateaued. Okay, last point. I know David's going to be touching upon this, but you can also use the indirect measurements of smoking attributable mortalities to look at subpopulations. So in Canada, for example, we've been able to quantify that smoking accounts for about half of the difference between rich and poor men. And if you break that down into what's happened over time, it's true that the richest have had the biggest declines, or the lowest prevalence in terms of smoking, but the poor are not getting left behind by tobacco control in Canada. That's the key point of this slide. So just to give you my conclusions on methods, all of these methods are possible, particularly I think the ICES work focusing on linkage to CCHS methods, and further extension of the indirect method would be possible. Thank you.